PSSD Hilfe Deutschland e.V. is a patient organization dedicated to promoting research into the causes, diagnosis, and treatment of PSSD. For more information, please visit pssd-hilfe.de. That's pssd-hilfe.de. Or follow us on Twitter at PSSD_Germany. In this video, we'll be covering the basics of post-SSRI sexual dysfunction. What is it? Which medications can cause it? Who can get it? What are the symptoms? And how can you diagnose it? PSSD is a disorder which can arise during or following treatment with serotonergic medication, usually SSRIs such as Prozac or SNRIs such as Effexor. All medications can cause unwanted effects. However, in PSSD, patients either continue to have unwanted effects after stopping the medication, or they newly develop unwanted effects when stopping the medication. In either case, symptoms persist despite stopping the medication. That's why we call it post-SSRI sexual dysfunction. The acronym PSSD, which stands for post-SSRI sexual dysfunction, is misleading because symptoms are not limited to the sexual sphere. Actually, symptoms often extend beyond sexual dysfunction and can, for example, include emotional blunting. As the term post-SSRI sexual dysfunction says, PSSD can be caused by selective serotonin reuptake inhibitors, SSRIs. We also know that PSSD can be caused by serotonin and norepinephrine reuptake inhibitors, SNRIs. In 2019, the European Medicines Agency issued a warning regarding the risk of persistent sexual dysfunction following SSRI and SNRI treatment. Most patients develop PSSD from either of the two medication classes. However, there is evidence that PSSD can also be caused by other antidepressants, by antipsychotics, and maybe even by other medications that interfere with serotonin. Here's a list of medications that have been mentioned in medical literature. It is very likely that this list is incomplete because PSSD hasn't gained much attention in medical research. The list is based on all medical articles on PSSD that have been published until 2023. It does not include what is often referred to as anecdotal case reports. Children, teenagers, and grown-ups of all sexes can develop PSSD. In medical literature, the sex ratio is usually 70-30, males to females, which doesn't necessarily mean that males are affected more often. There aren't any numbers for non-binary individuals so far. The age range in scientific studies is 15 to 66 years. However, there are anecdotal case reports of individuals who were treated with an antidepressant as a child and have suffered from persistent adverse effects ever since. Whether someone develops PSSD doesn't seem to be related to the duration of treatment or the daily dose taken. Furthermore, there doesn't seem to be a connection between the speed of discontinuation and the likelihood of developing PSSD. It is also important to highlight that some patients only develop PSSD when on their second or third course of treatment with the same medication. As the term post-SSRI sexual dysfunction says, PSSD is characterized by sexual dysfunction that persists after stopping the medication. The sexual symptoms often occur together with non-sexual symptoms which can, among others, affect emotional processing. The severity of symptoms usually has a direct effect on the quality of life. Most patients suffer from a sudden loss of sexual desire. The majority of patients also suffer from genital anesthesia and pleasureless orgasms. Most males suffer from severe erectile dysfunction. It is important to note that loss of sexual desire, reduced orgasm intensity, and erectile dysfunction are much less common in depressed patients and anxiety patients. In fact, genital anesthesia and completely pleasureless orgasms are not mentioned in connection with anxiety or depression at all. Further sexual symptoms that, based on available data, appear to be less frequent or have an unknown prevalence include delayed orgasm, which means that reaching an orgasm can suddenly take a very long time, like 30 to 40 minutes or more. Anorgasmia, which means that a person cannot achieve orgasm at all. Both orgasmic dysfunctions occur during sexual intercourse and masturbation. Absence of erotic dreams, which means that a person suddenly loses the ability to have erotic dreams. Male patients sometimes complain of premature ejaculation, which usually appears together with pleasureless orgasms. On the other hand, there have been reports of women who develop persistent genital arousal disorder following withdrawal. PGAD is characterized by unwanted sexual arousal without stimulation. Male patients, again, frequently report changes in semen volume and consistency. The volume is usually reduced, and the sperm watery. Some men receive abnormal semen analysis reports. Men sometimes also complain of changes in penis size. Women have reported changes in clitoris size. An analysis from 2020 found that 79% of male PSSD patients had varying degrees of erectile tissue inhomogeneity. Due to the lack of scientific interest in PSSD, this list of PSSD symptoms may be incomplete. There have been numerous case reports where patients complain of pain in the genitals, reduced lubrication, soft gland syndrome, and other symptoms of sexual dysfunction. Making statements about the non-sexual symptoms of PSSD is difficult because most of the research interest has been focused on the sexual symptoms of PSSD. However, from numerous case reports and 3 research papers on PSSD, we know that one of the most common non-sexual symptoms is emotional blunting. Emotional blunting is a state of reduced emotional reactivity, which means that a person can no longer feel happiness, sadness, and other emotional states. In fact, a recent study that was published in the journal Neuropsychopharmacology has confirmed that antidepressants cause emotional blunting in healthy volunteers. The researchers found that, under chronic escitalopram treatment, negative and positive effect was reduced. A dull feeling of emotional detachment from the world is one of the most distressing symptoms of PSSD. Other non-sexual symptoms include, but are not limited to, sleep disturbances, body numbness, cognitive issues, and altered reactions to alcohol and medications. Further research into the non-sexual symptoms of PSSD is needed. When it comes to diagnosing PSSD, there is currently no standardized procedure. Thus, the diagnostic process can be complex and may require multiple appointments with different healthcare providers. The diagnostic criteria for enduring sexual dysfunction after treatment with antidepressants that were published in 2021 by a group of 37 healthcare professionals can be used as a first step in identifying possible PSSD cases. However, usually a detailed medical history is required. Setting up a timeline of events can also be helpful. Finally, whenever a patient is diagnosed with PSSD, an adverse event report should be filed. Let's take a closer look at the diagnostic criteria. First of all, PSSD is only diagnosed if symptoms have persisted at least 3 months after stopping treatment. If the patient is still on medication, a diagnosis of PSSD cannot be made. Furthermore, to be diagnosed with PSSD, previous treatment with a serotonergic medication, for example an SSRI, is required. The second necessary diagnostic requirement for PSSD is a marked change in genital sensitivity. This is usually referred to as genital numbness or genital anesthesia. Patients fail to respond to genital touch because their genitals feel numb. In some patients, numbness is limited to sexual stimulation, others cannot feel pressure, hot and cold sensations either. As emphasized earlier in this video, genital anesthesia is not a symptom of depression or anxiety. Additional requirements are a reduction or loss of sexual desire, which is usually severe in quality, erectile dysfunction in males, which is usually severe in quality, and an inability to orgasm or reduced pleasure during orgasm. PSSD is ruled out if the patient suffered from the same type of sexual dysfunction before initiating treatment, if other illnesses could explain the symptoms, or if other medications or substances could be causing the symptoms. Before diagnosing PSSD, other illnesses should be ruled out. For this reason, it is recommended to test for hormone imbalances, specifically sex hormones, such as androgens, estrogens, progesterone, and prolactin. Furthermore, cardiovascular diseases, endocrine diseases such as diabetes, and urogenital diseases such as prostatitis can cause erectile dysfunction or, in extreme cases, numbness of the genitals. It is important to note that some sexually transmitted diseases can cause numb genitals, chronic itching, and severe pain in the genitals. Particularly if atypical or rare symptoms such as severe pain and itching are present, or if a patient's sex drive is unaffected, but erectile dysfunction occurs, a person should rule out causes other than PSSD. We would like to emphasize again that creating a timeline of events is crucial in diagnosing PSSD. Practitioners need to actively inquire about the quality of symptoms, as well as the onset and course of symptoms relative to the pretreatment state. A diagnosis of PSSD should be made if the case matches the diagnostic criteria, particularly if a. the patient suffers from sensory changes to the genitals and b. the symptoms were not present before treatment was initiated. Finally, we would like to emphasize once again that filing an adverse event report is crucial. PSSD is an underreported, underestimated, and frequently misdiagnosed adverse drug reaction. So if you or one of your patients is diagnosed with PSSD, please take the time to file an adverse event report. You can find a list of national competent authorities in the comment section to this tweet or in the video description on YouTube. For more information and support, you can turn to one of the patient organizations based in Australia, Canada, Germany, Italy, and the UK.